Good morning. Welcome to session. We'll start for this journey. So let's continue this pathology, general pathology. So if you could see here, this general pathology is arranged like a chapter wise, and don't think these are like a individual chapters like cell injury, inflammation. Don't think that these are the individual chapters. Actually, the chapters are so sequentially arranged that the knowledge you gain from one chapter, you will apply it in the next chapter. That is, if you are very thorough with the cell injury and the concepts in the cell injury and adaptation, you will be well equipped to learn this inflammation chapter very easily. So let's start with the cell injury and adaptations. Everything in this world has to be in a homeostasis. Everything want to go peacefully, but they face challenges. We face challenges. Similarly, the cell also face challenges. So the cell can be prone for many injuries. What do you think is the most common cause of cell injury? A normal cell. What is the most common cause of cell injury? Yes, let's be interactive and don't worry about whether you are right or wrong. Let's interact more. Yes, Tara, you are right. Hypoxia. Yes. So let's start writing this thing. Hypoxia is the most common cause of cell injury. And which is the most common cause of hypoxia? Hypoxia, we know reduced oxygen supply, but which is the most common cause of a hypoxia? It is ischemia. Ischemia is the most common cause of hypoxia. So we know that our body our body tissue cannot survive without blood supply. So ischemia is the reduced blood supply. So which cells or which tissues in the body is most susceptible to ischemia? Yes. Yes. So the most susceptible tissue to ischemia is neurons. Yes. Then comes the next question. The most resistant tissue to ischemia. Which tissue can survive with a long time with the ischemia? Yes. Can anybody make a try in the chat box? Bharatwaj. Good try, Bharatwaj. The answer to this is fibroblast. Fibroblast. Basically, what is this fibroblast? Fibroblasts are the cells which produce collagen in our body. Fibroblasts are the cells which produce collagen. You know, collagen is a connective tissue framework in our body, that is a supporting tissue. So basically, fibroblasts are the cells which are producing collagen in our body, and these fibroblasts are the cells which are most resistant to the ischemia. Yes. Okay. So whenever there is any injury, these type of injuries, and immediately the cell will not die. It will try to adapt to the new environment or new challenges or to the new stress. Yes, we also adapt ourselves to the new situations. From our school days, we adapted to the college life. From the college life, from the UG days, now we are adapting to a new situation that is the most challenging PG preparation period. So adaptations is a part and parcel of our life. Similarly, the cells also will try to adapt to the injurious stimulus. So let's see what are all the adaptations a cell can have. Hypertrophy. Yes. If I ask you this basic question, what is a hypertrophy and a hyperplasia? Yes, hypertrophy, you will say that hypertrophy is the increase in the cell size. Hypertrophy is the increase in the cell size, and hyperplasia is increase in the cell number. Hypertrophy is increase in the cell size, and hyperplasia is increase in the cell number. Then basically, let me ask you the next question. Which type of cells? Which type of cells will go for hyperplasia? Which type of cells will go for hypertrophy? So for this, you have to understand the cells which are capable of dividing. The cells which are capable of dividing will go for hyperplasia, and the cells which cannot divide will be going in for hypertrophy. So hypertrophy is increase in the cell size, especially in non-dividing cells, especially in non-dividing cells. When a cell size increases, what do you think? How the cell size increases? What is getting increased inside the cell so that the cell size is increased? Yes, it is increase in the proteins. Increase in the proteins. Inside the cell, intracellular proteins will be there, no? That protein content will be increased. So there is increase in the cell size. So what are the examples do you think? Yes. So the classical examples is like especially in the non-dividing cell. What are the non-dividing cells in our or tissues in our body? Heart, skeletal muscles. Yes, heart, skeletal muscles. So skeletal muscles, what do you think the hypertrophy? Yes, skeletal muscle hypertrophy occurs in bodybuilders. Skeletal muscle hypertrophy because these cells cannot divide. So they can increase in the size in bodybuilders and athletes. And also the classical example that is a pathological hypertrophy is left ventricular hypertrophy. Left ventricular hypertrophy, which occurs left ventricular hypertrophy, which occurs in hypertension as well as in aortic stenosis. Why in hypertension and aortic stenosis? Because the left ventricle has to pump against a great force because aortic stenosis, hypertension, there is a vascular resistance. After pressure, the load is increased. So what happened? The heart muscle has to pump, has to do more work against a stressful situation. So that is an injury and the adaptation is left ventricular hypertrophy. Yes. So as you can see from this picture, is this is a gross appearance of the cut surface of a heart. So you can see here, this is the right ventricle and you can see how much the thickness of the right ventricle, and compare it with the thickness of the left ventricle, how much big the left ventricle size has been, left ventricle muscle mass, the muscle mass, cardiac muscle has undergone this hypertrophy. So what is the consequence of this hypertrophy? You can see the cardiac chamber. The chamber size is narrowed. The cardiac chamber size is narrowed. This is about hypertrophy. Then hyperplasia, we know that increase in the cell number and it occurs in the fastly dividing cells. What are the classical examples of hyperplasia you know? Yes, in the males, it is BPH, benign prostatic hyperplasia. Almost 70% of the men above the 70 years of age, it is a physiological process which occurs in this 70% in above 70 years of age is this benign prostatic hyperplasia. Yes, so there is increase in the number of the prostatic glands, okay, in cells. And the other classical example is in females, that is a endometrial hyperplasia. Endometrial hyperplasia. So, which is the culprit behind this endometrial hyperplasia? The single most triggering factor for this endometrial hyperplasia is the estrogen. Estrogen. And why we should bother about this endometrial hyperplasia? What is the consequence of this endometrial hyperplasia? This endometrial hyperplasia is a predisposing factor for endometrial cancer. This is a predisposing factor for endometrial cancer. So remember, these are all the hyperplasia in the dividing cells. So let me ask you one question. What happens in the pregnant uterus? The uterus undergoes hypertrophy or hyperplasia? These are the questions asked in your previous exams. So other things usually you can understand, but hyperplasia or hypertrophy in uterus, just we have to concentrate more. And because that is a PYQ, let's hope this tabular column will solve your doubt. So pregnant uterus, both hyperplasia as well as a hypertrophy occurs. And please remember, if you have to choose one option, now you have to choose hypertrophy, which is more prominent than hyperplasia. But at the same time, remember, if it is like a multiple option question, all of the following can occur in a pregnant uterus. That means you have to choose both a hyperplasia as well as hypertrophy. And if you have to choose one option now, you have to choose hypertrophy. Coming to the breast during puberty as well as during pregnancy. Breast during puberty as well as during pregnancy undergoes both hypertrophy and hyperplasia. But the important point is breast during lactation. Breast during lactation undergoes only hypertrophy. Breast during lactation undergoes only hypertrophy. Only hypertrophy. This is the very, very important point you have to remember. Now, see this picture. This is the normal sized uterus. This is a normal sized uterus, and you can compare it with this pregnant uterus. See how much big the size is there. How much big the size is there. So let me ask you one question, guys. This is picture number one, and this is picture number two, which is taken from this uterus. And tell me which one is hypertrophy and which one is hyperplasia. Yes, make it a try. It is quite evident. Can you put it in the chat box? Which one is a hypertrophy and which one is hyperplasia? Is Vandana, Sadhuni, Veda, Tara, Bharatwaj? Yes, yes, very good. One is hyperplasia. Why it is a hyperplasia? Yes, Devasena. Yes, Ataf Hussain. Yeah, hyperplasia. You can see here, these are all the nucleus of the smooth muscles. These are the nucleus of the smooth muscles which have gone for this hyperplasia. And you can see here, this is a single cell which has gone for hypertrophy. Hypertrophy. Remember the increase in the muscle size, that is because of the increase in the protein. Protein. It is not the nucleus increase, Bharati. Nucleus will be of the same nucleus increase, you mean hyperplasia. Hyperplasia, the increase in the cells, increase in the number of the cells, so the nucleus is increased, that is hyperplasia. And you can see here the nucleus is almost remaining the same size, but the cytoplasm is increased, Bharati. So only the nucleus size is increased, cytoplasm is increased because of the protein content. Okay. And atrophy is, all of us know that it is decrease in the cell size as well as cell number. Hypertrophy is because of the increase in protein content, but atrophy is decrease in protein content or increase in protein degradation. Increase in protein degradation. This brings us one of the important MCQ, which is the organelle for protein degradation. Which is the organelle for protein degradation? Organelle inside the cell. Inside the cell, you call that as an organelle, and the organelle for the protein degradation is proteosomes. Proteosomes. And this was a previous year question. Which enzyme is responsible for this protein degradation? That is ubiquitin ligase. Ubiquitin ligase. So ubiquitin ligase is an enzyme, is a protein which is responsible for protein degradation inside a cell. And the organelle in which the proteins are degraded are called as proteosomes. Proteosomes. And one more important question, in the 2022 NEET, they have asked what is the reason for atrophy of the brain in old age? Yes, we all of us know. Please remember this one important point. Brain undergoes atrophy at old age. Brain undergoes atrophy at old age. And 22 NEET asked the question why the brain undergoes atrophy in the old age. Can anybody think why as age advances the brain undergoes atrophy? Atrophy of the brain. This is because of the ischemia, ischemic injury, ischemia. Why ischemia? Because as age advances, what happens inside the blood vessels? Inside the blood vessels, that the thrombus and the atherosclerotic plaque tend to develop, no? So the cerebral vessels, the reduced blood supply to the cerebrum at old age because of the thrombus. So all this leads to the ischemia to the brain parenchyma. So brain undergoes ischemic atrophy in old age. Ischemic atrophy. Then what is this disuse atrophy? So it is a well-known fact. That is, after fracture, what will happen? They will be immobilizing the limb. After fracture, they will be immobilizing the limb. So they will be immobilizing for 8 weeks or 12 weeks. Then after this 8 weeks or 12 weeks, when the POP cast is removed, the muscles would have undergone atrophy. What happened in a hypertension and aortic stenosis? The cardiac muscle was doing overaction, so more work, so the muscle gone for more increase in the size, that is hypertrophy. But here the muscle is not being used because you have immobilized the limb. So after you remove that, POP cast, this will result in the pressure means disuse atrophy. After fracture. Then the other type of atrophy is denervation atrophy. What is this denervation atrophy? That is, a nerve supply is needed for the muscle to contract. So imagine, guys, if a nerve supply is cut off, that means what? There is no one to stimulate the muscle. So after nerve supply, nerve injury, nerve damages, there is no one to stimulate the muscles. So the muscles will go for atrophy after nerve injuries. That is denervation injuries. Then what is this denervation atrophy? Then what is this pressure atrophy? Imagine a patient is having a big abdominal swelling, a big abdominal tumor. What happens? Because of the increase in the tumor size, the tumor will compress the adjacent organs, the visceral organs. So because of the pressure, the organs will be going in for atrophy. That is a pressure atrophy. Then hormonal based atrophy. What happened? After menopause. What happens? The breast size and the breast the breast size as well as the uterus size decreases because of the lack of the hormones. So this is called as hormonal atrophy. And also this osteoporosis is also a type of atrophy. So remember, atrophy is decrease in the cell size as well as cell number. Then comes the one of the very high yield topic for the day, that is the metaplasia. What is this metaplasia? Metamorphosis or metaplasia. Metaplasia is nothing but it is a conversion of one type of cell to the other type of cell. So basically, when I say that cell type, what is the cell type? How many types of cells are there in our body? Remember, guys, very basic concept which will helpful for you to understand your neoplasia chapter, also very important. There are two types of cells in our body. One is called as epithelial cells, and the other one is called as the mesenchymal cells. What is this epithelial cells? Epithelial cells are the cells which are the lining surfaces, which are seen in the linings like skin surface, GIT organ. So that the lining cells are called as epithelium. And what is this mesenchymal? The mesenchymal cells are nothing but the connective tissue, like your bone, cartilage, muscle, fibrous tissue, which gives support and a connective tissue. These cells are called as epithelial cells, and the lining cells and the connective tissue cells are the mesenchymal cells. Similarly, metaplasia is what I told. Conversion of one type of cell to other. So there are two types of metaplasia. One is called as epithelial and the other one is called mesenchymal. So why do you think the cell suddenly changes its shape, suddenly changes its morphology? How? What happens? That is the actual problem. This metaplasia occurs at the level of stem cells, at the level of stem cells. Because stem cells has the property of differentiating into one type of cell to another cell. So this metaplasia occurs at stem cell level. Metaplasia occurs at stem cell level. So epithelial metaplasia. What is this epithelial metaplasia? See this picture. So this is what is the normal lining epithelium of the respiratory tract? The normal lining epithelium of the respiratory tract is pseudostratified ciliated columnar epithelium. Pseudostratified ciliated columnar epithelium. See this? This is the pseudostratified stratification, multiple layers, and you can see this small cilia. Small chinna cilia, kuti cilia are there. Why this is why this is the lining epithelium of the respiratory tract? To filter from the foreign agents and also from the dust. All this thing, the body is designed to make this thing lined with this epithelium. But what happens in smokers? When there is a constant smoking, when the patient is exposed to constant smoking, this pseudostratified ciliated columnar epithelium is getting converted into squamous, that is a multi-lined epithelium. Why particularly squamous? What is the purpose of squamous epithelium in our body? See your body as a whole. Wherever the body is exposed to the external environment, say for example the skin surface, oral cavity, esophagus, anal canal, vagina, ectocervix. So whenever there is exposure to outside environment, the body is designed to be lined with this squamous epithelium with the multi-layering type of thing, so that can withstand the stress. So what happens because of the chronic smoking? The pseudostratified ciliated columnar is getting converted into squamous. So this can occur, and now this is called as squamous metaplasia. And why we have to bother about this squamous metaplasia? Do you think it is reversible or irreversible? Please try to answer this. Yes, can anybody think metaplasia is reversible or irreversible? What do you think, guys? Can the squamous epithelium can again be converted into a pseudostratified ciliated columnar? Ah, yes. So here, some catch is there. Hussein, Bharatwaj, and she. Initially, it is reversible. That is, if the person stops smoking, then initially it is reversible. But if the patient keeps on damaging giving the continuous stimulus, then it becomes irreversible. So that is the point you have to know. Initially reversible, but on continuous injury, the metaplasia can turn into squamous cell carcinoma, malignancy, cancer. Okay, so please remember that. So this is the squamous metaplasia. Then what is this in GERD? What occurs? That is in the gastroesophageal reflux disease. In the gastroesophageal reflux disease, what happens, guys? See here, the lower end of the esophagus. The esophagus is lined by the stratified squamous epithelium. So see this, esophagus is lined by stratified squamous epithelium. So what is the lining epithelium of the stomach? The lining epithelium of the stomach is this columnar epithelium. that is a cuboidal to columnar epithelium, which can withstand the stress of the stress of acidity, gastric secretion. Squamous epithelium is not designed to withstand the stress of the acidity. So what happens in GRD? This squamous epithelium of the esophagus is constantly exposed to the acidic environment from the stomach. So what happens here? It is getting converted into columnar epithelium. Here it is getting converted into columnar epithelium, and so this metaplasia is called as, in GRD, which occurs, is called as columnar metaplasia. Columnar metaplasia. Sometimes among these columnar cells, you can see these bubbly cells, where you will be getting these cells with bubbly, vacuolated cytoplasm. These cells are nothing but these cells are the goblet cells. Yes, where you will see goblet cells. Goblet cells are usually seen in the intestine. So if a lot of goblet cells are seen, then this metaplasia is called as intestinal metaplasia. Intestinal metaplasia. So squamous metaplasia in lung would have given rise to a squamous cell carcinoma, whereas columnar metaplasia can give rise to which carcinoma, guys? Columnar cells. Which is the malignancy which arises from the columnar cells? What is the malignancy which arises from? So
So
that
that
is
is
adenocarcinoma. The malignancy arises from the columnar cells is the adenocarcinoma. So let me ask you one important question, guys, which has the surgery integration. So what is this type of esophagus in which the esophagus is getting converted into columnar metaplasia, and that increases the risk of adenocarcinoma of the esophagus? What is that name of the esophagus in surgery? You would have read. Yes, Altaf, you're right. Yes, Tara. It is Barrett's. So this actually gives rise to this Barrett's esophagus. And this is, yes, Vandana, you're right. This is actually very important question. Which is the malignancy? Which is the most common malignancy of esophagus overall? It is squamous cell carcinoma, because squamous esophagus is lined by stratified squamous epithelium. Which is the most common malignancy in the upper one-third of the esophagus? Squamous cell carcinoma. Which is the most common malignancy in the middle one-third of esophagus? Squamous cell carcinoma. Which is the most common malignancy in the lower one-third of the esophagus? Then it is adenocarcinoma. Why it is adenocarcinoma? Because Barrett's esophagus is lying in the lower one-third of the esophagus, no? So adenocarcinoma arises from the Barrett's esophagus. So adenocarcinoma is the most common esophageal malignancy in the lower one-third of the esophagus. This is very important. These are some of the examples of epithelial metaplasia. Epithelial metaplasia. Now we'll see what is this mesenchymal metaplasia. What is this mesenchymal metaplasia? Mesenchymal metaplasia, that I told, no, bone, cartilage, muscle, and these things. Let me give you one example. What is this myositis ossificans? Myo means muscle. Citis means inflammation of the muscle. Ossificans, that is what happens. Bone formation occurs in the muscle. So this is called as myositis ossificans. So when myositis ossificans occurs, especially as a complication of the fracture healing. Yes. So what happens usually in the fracture healing? We will adjust. No, we will advise them. No, don't go for this native treatment because they will be manipulating, crushing, and all squeezing. All this thing happens in the native treatment. So what happens when the injured muscle, when the muscle is given more stress? So there occurs a bone formation within the muscle, and that is the ossificant. So this is a type of mesenchymal metaplasia. Mesenchymal metaplasia is, this is the osseous metaplasia, that is a bone formation occurs. Then what is this cartilaginous metaplasia? Especially in a fracture healing. After a fracture, why do you think that we are immobilizing a limb after fracture? Why we are immobilizing the fractured site in a POP cast? Because we are immobilizing the limb. Because immobilize only will be help in the callus formation, so that the fractured bone is getting healed. So that is the funda behind that. But imagine a patient, limb is not immobilized properly. He keeps on using his limb, so the fractured site constantly keeps on rubbing, constantly they keeps on rubbing. So what happens? Whenever there is any friction or whenever there is any space between the movement between the bones, so what happens? There occurs a cartilaginous metaplasia, because you know that in a joint also at the articular surface, what happens in the articular surface in the joint also? There occurs a cartilage. There occurs a cartilage in the articular surface. So, in a not properly immobilized arm fracture, when it is constantly moving, so what happens? There occurs a cartilaginous metaplasia. Cartilaginous metaplasia. So this is a very important topic, very important thing, guys. Okay, so this is about the cell injury adaptations, adaptations especially. Yes, that hyperplasia, hypertrophy, metaplasia, and this atrophy. So now, guys, we'll be moving into the types of cell injury. So we have crossed some nearly one half an hour. So let me ask you guys, do you want me to continue the sessions in the same speed, or do you want me to increase the speed? How you feel? So it's up to the content is tailored to you. So based upon your need, I can say you, do you want me to increase the speed, or are you comfortable with this speed, or any other suggestions? Yes, Niranjana. Thank you, Bharatwaj. Okay. Okay. So if you are having any uncomfortable, okay, thank you, Sadhani Veda, thank you, Devasena. If you are having any uncomfortable, or if you are not understanding any point, you want me to repeat some point, or you want me to slow down in certain areas also, feel free to put it in the chat box. Okay, because the ultimate aim for this session is, it's not me who is finishing the portion so that to say that the general pathology is over. It's you should be in a comfortable manner. You should be enough to answer any type of question which answered, which they ask in this exam. So that is the motive of this session. Okay, so feel free to interact with me at any point of time. Okay, so now we'll be moving on to the types of cell injury. Yes, I told, whenever there is any injury, what happens? The cell try to adapt itself. But if the injury is very severe, injuries keep on occurring, then the body will not have any enough time for that cell adaptation, or it get fatigued of this cell adaptation. So what it will do, it will undergoes injury. So the types of injury can be, there are two types of injury. One is reversible cell injury and the other one is irreversible cell injury. What is this reversible and irreversible? Yes, Hussein, you are right. Reversible damage is caused by mild injuries. Whenever the injury becomes very severe, the cell goes in for irreversible injury. Okay, it is if it is a continuous stimuli or if it is a very strong stimuli, the cell will be going in for irreversible cell injury. That is a form of cell death. So what happens during this reversible and irreversible cell injury? First, we'll see what happens in a reversible cell injury. So reversible cell injury see this, whenever a cell undergoes any injury. So what happens? The ATP, which is the energy currency of a cell, the ATP level drops. Yes, the
The
ATP is
ATP
the
is the
energy
energy
currency
currency
of
of
a
a
cell,
cell,
and
and
the
the
ATP
ATP
level
level
drops.
drops.
So this ATP level drop will result in the decrease in the sodium potassium ATPase activity. Yes, recollect from your physiology. What will happen if the sodium potassium ATPase activity is decreased? Yes, there will be increased sodium entry into the cell. Increased sodium entry into the cell. And what will happen if sodium is entering into the cell? More water also enters into the cell. Yes, so there will be increased water entry also into the cell. Increased water entry also into the cell. So ultimately, the cell size swellens. The cell size is increased. In hypertrophy, the cell size is increased because it is increase in the protein content. In reversible cell injury, the cell size is increased, swollen because it is increased in the water content. So what happened? All the cell organelles, see this? All the cell organelles, endoplasmic reticulum, mitochondria, everything is getting swollen. Everything getting swollen. Organelle. Guys, which is the organelle for protein degradation? Yes, can you recollect immediately? Which is the organelle for protein degradation? Few minutes back we saw protein degradation. Proteasome, very good. Okay, and also please recollect it is ubiquitin ligase, ubiquitin ligase that enzyme. Okay, so let's see this. What is the material inside the nucleus is called? Nucleus, you would have seen, no, that cytoplasm will appear pinkish and the nucleus will appear blue. And what is the nuclear material? That blue color material is called. That is called as chromatin. That is called as chromatin. The nuclear material is called a chromatin. Why it is called a chromatin? Because nucleus contains the chromosomes. So the nuclear, the blue color material is called as chromatin. Okay, let's come here. What happens to the nuclear chromatin here? Here there will be some clumping of the nuclear chromatin. That blue material is there, no? That tends to clump together. Okay, so that is one important point. Another important point you have to note down is mitochondria is also getting swollen. That is the powerhouse of a cell. The mitochondria also is getting swollen, and you can get small densities in the mitochondria. Small densities in the mitochondria. Note down this because there is one important MCQ coming up in the irreversible cell injury. In mitochondria, there is a small densities which is occurring. So let's see this picture. What is this organ, guys? What is this histopathological image, pink and blue image? Which organ they are showing this? Yes, which organ it is showing? Don't worry, right or wrong. Yes, Niranjana. Yes, Altaf Hussain. So it is kidney because you could identify that this is the glomerulus, this is the glomerulus, and these are all the capillaries. These are all the capillaries. But do you think these are all the normal capillaries, guys? Yes, Bharati, it is kidney. But see here, do you think this is the normal capillary? No. Sorry, these are the normal tubules? No. These are nothing but the swollen tubules. Swollen tubules. You can see the tubular size is increased. And why the tubular size is increased? Because it has undergone a reversible cell injury. So this change is called as hydropic swelling. What is hydro? Hydro now water. So here the cell size is swollen up, is bigger because there is lot of actually water inside it. And this is in which condition? It occurs in acute tubular necrosis. And like we were talking about reversible cell injury, uh, Subhash, chat box. So there will be acute tubular necrosis. Acute tubular necrosis. So what happens? This is a reversible cell injury. So reversible cell injury. What happens because of the sodium potassium ATPase? That thing has got lost. So there will be more water entry into the there will be more water content. There will be more water content. So all the cells, all the tubules will be swollen up, all the tubules will be swollen up. See this, these are all the tubular cells, these are the tubular cells, and this actually will be white in color. Why it is white in color? Because it is actually loaded with the water. So loaded with the water. So this is how this occurs, white in color, white in color. So this is a reversible injury, reversible injury. So now let's see in the irreversible injury. What happens when there is a irreversible injury? So whenever there is any irreversible injury, it is mainly the culprit. The thing which occurs here is the increased calcium entry into the cell. That is when the stimulus is very strong, or when the stimulus is continuing for a longer time, cell has not given any chance for any reversibility. So the cell can't cope up with the situation, and the cell undergoes a irreversible cell injury, that is a cell death. So whenever the cell irreversible cell death, that point is coming, no, there occurs an increased cytosolic calcium. So this increased cytosolic calcium has been actually will be having some role. It will be activating three important enzymes. The increased cytosolic calcium will be activating three important enzymes. The first enzyme is the phospholipase. Guys, what do you know? Phospholipids. All the cell membranes in our body, yes, in the biochemistry we have read, all the cell membranes in our body are made up of phospholipids. So phospholipase is the enzyme which degrade the phospholipids. So what will happen if the cell membrane itself is degraded? Then occurs a membrane damage, a membrane damage. So that increased calcium entry stimulated that phospholipase, degraded the phospholipids. So there is a membrane damage. The next enzyme activated is the protease. So what is this protease? It degrades the protein. What type of proteins? So it actually like a skeleton. We have our body has skeleton, no, which gives a proper shape. Similarly, each and individual cell has got some cytoskeleton, which proteins, they are basically proteins, which gives a shape to the cell. For that only you are calling this is a cuboidal cell, this is a columnar cell, squamous cell, because of their shape only. So the shape is given by the cytoskeleton. So that protease, that enzyme activated, so it degrades the cytoskeletal proteins. It degrades the cytoskeletal proteins. And further, what enzyme is again getting activated? Endonuclease. So the nuclease is getting activated. So there will be nuclear damage will be there. So what are the three important things? Phospholipids, cell membrane damage, and then protease, cytoskeletal damage, and also endonuclease, that is the nuclear damage. Nucleus damaged, cytoskeleton damaged, membrane damaged. How you expect the cell to be alive? So there occurs a cell death. That is a irreversible cell injury. So what happens to this? You have seen the morphology of a reversible cell injury. Now see what happens in this irreversible cell injury. The first important thing to be noted down here, compare it with a reversible cell injury, the cell membrane was intact here. Though there are some blub formation because of the water, turgid water blowing out. So, but the membrane is intact. Okay, note down this, guys. The membrane is intact. But see here, the phospholipase was damaging the phospholipid membrane. So there will be membrane damage occurs. The membrane damage occurs where we are talking about irreversible cell injury. Another important thing, guys. This is your important PYQ, especially the NEET question, about the types of the nuclear changes which occurs in a irreversible cell injury. Three nuclear changes we are now going to remember, guys. First nuclear change. What is that first nuclear change? That is Pycnosis. What is this pycnosis? The nuclear material, no, that blue color material. That nuclear material will be very condensed in a very dot-like nucleus. So pycnosis means it is dot-like nucleus. It is a dot-like nucleus, condensed, very much condensed, dot-like nucleus. Then what is the second nuclear change which can occur? That is the karyolysis. Karyolysis. What is the study of chromosome, guys? Study of the chromosome, you must have heard of karyotyping. So karyo is something to concern with the nucleus. So karyolysis, that is the nuclear material, that is the blue color nuclear material would have been dissolved, gone for lysis, dissolved. So this is called as karyolysis. So karyolysis means dissolution of nuclear material. So that is the karyolysis. So pycnosis and karyolysis. What is the third nuclear change? Karyorexis. As you can see from here, karyorexis. Please open the chat box. Karyorexis. Karyorexis is dissolution, that is the nuclear material is there, no? Nuclear material. That nuclear material is getting fragmented. See this? Karyorexis. So the nuclear material is getting fragmented. So pycnosis, karyolysis, and Karyolexis. Yes. So these are the three nuclear change. And remember, guys, in the mitochondria, I was telling you in the reversible cell injury, please remember what you remember. There will be some small densities in the mitochondria. But please remember, mitochondria, which is the powerhouse of a cell, that is getting shut down. Powerhouse is getting shut down in irreversible injury. Why? Because it is replaced by large densities, and the characteristic keyword in every exam, the same keyword is being asked, is how the densities will be. It will be large, amorphous, flocculent densities. Large amorphous flocculent densities. This is the keyword in the mitochondria. You will be getting this large amorphous flocculent densities. That is a sign of irreversible cell injury. That is a sign of irreversible cell injury. Okay, so these two things we are going to remember. In the nuclear, pycnosis, karyolysis, karyorexis, membrane damage, and also this large amorphous flocculent densities. Membrane damage, I was saying you. So the phospholipids were degraded. So these phospholipids, the degraded phospholipids, what is inside the cell now? In the irreversible cell injury, which is in excess, calcium is in excess, no? So this phospholipids plus that excess calcium forms a world structure. This world structure that is called as myelin figures. So please remember, these are all the myelin figures. So myelin figures are made up of phospholipids plus calcium. This is usually commonly seen in irreversible cell injury. Note down my words. I'm saying commonly seen in irreversible cell injury, but that means in reversible cell injury also it can be seen, but the incidence is very less, but can be seen. So so it depends on the question how the examiner asks. Myelin figures commonly seen in, if you have to choose one option now, that is irreversible cell injury. Myelin figures can be seen in all of the following. Abdina, reversible injury as well as irreversible injury, you have to choose. Yes. Now, what is this image, guys? You know, pink and blue, na, that is a hematoxylin eosin stain. But what is this, a black and white images? Please remember, in the image-based questions, a good proportion number of questions are being asked in this exam. And this black and white images means it is an electron microscopic image. So what is this electron microscopic giving images showing you? It is nothing but this myelin figures. Yes, this is the electron microscopic picture of the myelin figures. So remember, it is phospholipids plus calcium, plus calcium. This is that world appearance. Yes, that world appearance. World appearance. Yes, remember this, guys. Okay.
Okay, so we are starting that free radical mediated injury. So there, from there only all this started. So free radicals cause much damage, no? So remember that. What are free radicals? We discussed all the atoms. Okay, all the atoms will have the outer shell will have paired electrons. Free radicals are the components actually which have an unpaired electron. Just it says everyone is in with pair. I alone with not having any pair. So what happens? This unpaired electron tries to target or tries to attack the other molecules, that is the DNA rich particles, especially this electron rich particles, especially this DNA and all are being targeted by this free radicals. So what is the purpose of these free radicals? Actually, they are implicated. These free radicals are implicated in many of the diseases of humankind: cancer, atherosclerosis, aging. So all these diseases, this free radicals plays a major role. And what is this ROS? So ROS are nothing but reactive oxygen species. Yes, ROS are nothing but a reactive oxygen species. Yes, many places we would have come across this terminology, ROS. So now let's see what are these ROS. So let's see this flow chart. Oxygen on loss of this free radicals or on loss of this electron will be converted into superoxide. Superoxide is nothing but it is O2 minus. Yes, so superoxide will be further converted into hydrogen peroxide, H2O2, and this hydrogen peroxide will be converted into hydroxyl ions. This hydrogen peroxide will be converted into hydroxyl ions. So please remember, this hydroxyl ions is the most potent free radical. Hydroxyl ions is the most potent ROS or the free radicals. And also please remember, this superoxide will be converted into hydrogen peroxide with the help of the enzyme. So we were talking about unpaired free radicals. Free radicals are the substances which have an unpaired electron in the outer shell. See, all the electrons in an atom, all the electrons in the outer shell are pair, but there is only one So guys, we stopped with this history of fat necrosis. Like we started with the acute pancreatitis, remember? So, and this, you remember, guys, the 28-year-old male presented with a severe abdominal pain radiating to the back. Yes, you made a diagnosis of acute pancreatitis. What is the pathogenesis? The duct system in the was disrupted, and all the enzymes, amylase, lipase, everything comes out of the pancreatic duct, and it start digesting the omentum and the mesenteric pad of fat. So this is how fat necrosis occurs in acute pancreatitis. So fat necrosis, please remember the clinical scenario. It is acute pancreatitis. Acute pancreatitis. Where else the examiner can give you the history of fat necrosis? So imagine a fat-rich organs in our body, like breast and in the buttock regions. A simple trauma can initiate the fat necrosis in these organs, in these regions. So in breast and in the buttock regions, a trauma can precipitate a fat necrosis. So what happens during this fat necrosis when amylase and lipase acts on this fat depots? There will be release of free fatty acids. Yes. So there will be release of free fatty acids, And these free fatty acids, like in any case of an irreversible cell injury, these free fatty acids will be combining with the calcium. They will be combining with the calcium, and this process is called as a saponification. This process is called as saponification. So what is this saponification basically? It is a free fatty acids plus the calcium resulting in this chalky white deposit. See this. This is our exam question. Chalky white deposits. Chalky white deposits. And as you can see here, this is the omental tissue. How will you identify a omental tissue? That is, a fat-rich organs usually appear yellowish in color. Lipoma, yellow in color. Fatty liver, yellow in color. Omentum, mesentery. So everything appears rich in fat, appears yellow in color. So in this omental tissue, if you could see this chalky white deposit, so this process is actually your process of saponification. Guys, do you remember where else we discussed this calcium plus your phospholipids? Yes, few hours back we have discussed. Can anybody recollect and put it in the chat box? Phospholipids plus calcium in irreversible injury, electron microscopic finding. Can you think? You can recheck your notes and can put it in the chat box. Yes, very good, very good. That is myelin figures, myelin figures. So myelin figures, very good, Bharati. Myelin figures are the world appearance. Yes, Hussein. It is myelin figures which has this world appearance which can be appreciated in electron microscopy. Yes. Okay. So now moving on to the fibrinoid necrosis. Fibrinoid. So in pathology, if you hear the word oid, O-I-D, oid, oid means like. That means fibrinoid means it is fibrin like. That means actually it is a misnomer. It is not like fibrin like material, it is the actually the fibrin material which is deposited here. So the key word we are going to remember with this fibrinoid necrosis is vessel. Anything connected with the vessel plus the necrosis they are asking, think of fibrinoid necrosis. In fibrinoid necrosis you are going to remember three letters diseases. Yes, three diseases which shortly called as three, written in three. Yes, SLE, rheumatic heart disease, hypertension. So this three letters word, we will remember fibrinoid necrosis. So SLE, a connective tissue disorder, autoimmune disorder, you will be getting the fibrinoid necrosis. Rheumatic heart disease, the so-called Ashcroft body, we will be discussing in our systemic pathology. We will be having this fibrinoid necrosis. And this hypertension in the blood vessels, you will be having this fibrinoid necrosis. So basically, what is this fibrinoid necrosis? You can see here, this is the blood vessel. How I am saying that this is a blood vessel? Yes, sir. So this is, see this? This is the lumen which contains this orangish. What are these things inside the lumen? So this is the RBC. So this is a structure with RBC. So obviously it is going to be a blood vessel. But what the point to be noted for us that is very important is, see this in the vessel wall. Can you appreciate this? Some bright pinkish material, some bright pinkish, and it looks very much fibrillar in nature. See this bright pinkish material. So this is what called as the fibrinoid necrosis. Fibrinoid necrosis in the vessel wall. So basically you can ask me, sir, how come fibrin is inside the blood vessel, how come this will come deposited outside the blood vessel, and that too in the walls of the blood vessel? What could have made them to find in the walls of the blood vessel? That is, it is basically the antigen antibody reactions. See, in SLE and many of these vasculitis, the antigen antibody complex, there may be some autoimmune disease, no? So that antigen and antibody will form a complex, and this antigen antibody complex would have been deposited in the vessel wall. So this antigen antibody complex would have elicited some immune reaction, and this would have resulted in the damage of the blood vessels, and that caused this fibrinoid necrosis. That is the leakage of the fibrin from the blood vessels and getting deposited in the vessel wall. Fibrinoid necrosis. Yes. So can we have a quick recap of the different types of necrosis in just 2 minutes? Yes. Necrosis, we saw it is an irreversible cell injury. So it is an ischemic injury. Solid organs like a heart, kidney, and spleen are getting affected. And the denaturation of the proteins is a keyword. And the tombstone appearance. What is the tombstone appearance? Outer architecture preserved and inner nuclear details lost. Yes. And also see this liquefactive necrosis. You will remember brain, abscess pus, and hydrolytic enzymes. And dry gangrene, it is gangrene, it is the necrosis with the superadded putrefaction. So basically two types of gangrene. Dry gangrene, it is common in the arterial occlusion and common in the limbs, and TAO, that is thromboangiitis obliterans, is the main disease causing this dry gangrene. Wet gangrene in the moist areas in the venous occlusion, intestine, diabetic foot, and the bed sores. And the gas gangrene, it is gram-positive agents, Clostridium perfringens, that is thing. And caseous necrosis, I'm going to remember caseous nachisi, that is in the tuberculosis. And this fat necrosis, we saw acute pancreatitis, breast and buttock region trauma. And this chalky white deposit, they are nothing but the free fatty acids plus the calcium. And fibrinoid necrosis, I'm going to remember it is blood vessels, SLE, rheumatic heart disease, and in the hypertension. Yes, so these are the key points which we can remember in this necrosis. And our examiners, the question is going to be asked around these topics only. Yes, please remember that only these topics are enough.